Good morning, everyone. My name is Tara DePonte. I am with the Plan Management Division here at Covered California. Welcome to the 2024 through 2026 QDP Issuer Model Contract Refresh Work Group. Today's focus is on health promotion and prevention. So for our agenda today, I'll start us off with a quick review of our timeline and work group approach. Next, Taylor Priestley, Deputy Director of the Health Equity and Quality Transformation Division here at Covered California, will provide background and information on Covered California's role as a purchaser. We are excited to have two very knowledgeable guest speakers today on our topic. Dr. Paul Glassman, Professor and Associate Dean for Research and Community Engagement at California North State University, is here to speak to us on an evolving oral health industry. And Dr. William Jackson, co-founder, COO of Virtual Dental Care, will be discussing opportunities in technology to engage members. Following both presentations, we'll then open up the floor for questions and discussion, followed by next steps and wrap up of the meeting. So on our next slide, I updated and extended the time frame for one-on-one meetings with stakeholders to July, since we continue to have additional discussions past our initial kickoff meetings. And we would be happy to schedule any additional one-on-one meetings should any of our stakeholders make that request. The rest of the timeline remains unchanged, with our work group meetings running from April through July. Then the posting of our first 2024 QDP contract draft and public comment cycle period will occur between August and October, with the draft to the board for discussion in November and final draft to the board for approval in January. So before we jump into our topic, I wanted to quickly review our work group approach. Overall, these work group sessions and discussions are to develop concept proposals for the 2024 QDP contract refresh based on the framework, principles, and priority areas for focus that have been presented and developed with this group. So at this moment, our work group will meet through July with next month's topic centered around data and measurement. For today's meeting, please feel free to share any ideas, feedback, or suggestions you may have. Open discussion and conversation is very welcome and necessary even to help us, help guide us with these contract provisions. So please feel free to pose any questions you might have in the meeting, type in the chat, or raise your hand. So we also think that there may be value in extending these work group sessions for August and possibly September. We're open to meeting again on topics the group would like to engage in. This could be a wrap up of previous topics with a preview of the contract draft, or it could be topic specific on an area we have yet to cover, or it could be a follow up to any of the previous topics that participants feel need further discussion. So I wanted to ask the question to the group if you had any immediate feedback on whether you would like additional work group meetings, particularly in August and September.
Tara, there's a question that all the dental plans had a one-on-one in the beginning, but will those continue, or are we just going forward with work groups?
We had just planned for those initial one-on-one kickoff meetings with the dental carriers, but if additional one-on-one meetings would be beneficial, then we're open to scheduling more if carriers would like that. You can definitely reach out and email us and we can set that up.
Thank you.
Mm-hmm.
Hi, this is Delta. I think that we would prefer to have additional work group calls in, I think you said August and September.
Yeah. Okay.
Yeah. We would support
Great.
that.
And is there any feedback on the topics people would like to cover? If you don't know today, then you can definitely, we can send out an email asking that question so that we can get some feedback.
Yeah, I will definitely pull the team and get together a list of topics that we would like to discuss.
Okay, great, thank you. Oh, can someone, there we go. Okay, with that, I'll go ahead and hand things over to Taylor Priestley so that she can talk to you all on Cover California's role as purchaser.
Thank you, Tara, and good morning, everyone. We realized in our last meeting in May, which we had realized in the previous month as well, that we here at Cover California had sort of dived right in, fresh from the health plan refresh. And we have really enjoyed both the diversity of participants in this dental plan contract refresh, and the level of engagement. We have really appreciated the discussions we're having here in the work group, and the number and the frequency that we're meeting with folks individually as well. It's really deepening our understanding of kind of where the industry is and where we should be focusing our efforts. But we've realized in a couple of successive work groups meetings now that we could have done a better job kind of reminding folks of who we are, how we're organized, how we operate. So we spent some time in the last meeting looking at how dental benefits are treated under the ACA, walking through how we approach benefit design, the products that we offer for sale, and how adult and pediatric dental are different. And we realized in discussion we could have done a better job of stepping back even one step further and reminding folks or letting folks know who are newer to these conversations how we are organized, how our authority works, and sort of what our purchaser levers are. So just to start with the basics here, we are an independent public entity. We are completely self-sustaining financially. We're funded through premium assessments on the health and dental plans that we sell to the public. We do not receive any funds from the California General Fund. We are all staff are state of California employees, but we are an independent public entity. And our core charge as a state-based exchange is to foster and facilitate this competitive marketplace. And we have in our enabling legislation the authority to conduct selective contracting. So that means we are able to set our participation criteria kind of above the minimums of the federal qualified health plan certification requirements. And it also gives us authority to do things like actively negotiate the premium rates with our carriers for health and dental. It also gave us the authority to establish standardized patient-centered benefit designs, and gives us the authority to set contract terms that we choose to establish in alignment with the other purchasers and with the express purposes of improving health, reducing health disparities, improving health care quality, and ultimately working to support transformation of the delivery system to support those goals market-wide. So again, we are governed by a 5-member board. All of our work is subject to their approval. So on the next slide, we can talk in a little bit more detail about those various components and how we approach this work. So we're talking a lot in this work group meeting about our qualified dental plan issuer model contract. So that is a standard model contract that applies for all participating issuers. And we've talked about how attachment 1 will contain all of our requirements and the incentives to improve oral health, dental care quality, reduce disparities, and again, some of those elements of delivery system transformation. And our attachments 2 and 3 are the performance standards and expectations, some of which are subject to financial consequences and some are not. But that's where we will be increasing our emphasis on health improvement and disparities reduction outcomes. So that model contract applies for all contracted issuers. the first step, though, to participate with Covered California is the QDP certification application process. So as a state-based exchange, we have to at least meet, and we choose typically to also exceed federal qualified health plan certification standards. And we really work hard to align that certification application with our contract priorities so that we are selecting qualified dental plan issuers that will be able to help us deliver on those priority outcomes around health improvement, disparities reduction, and delivery system transformation. We want to make sure that we are best meeting our consumer needs. So there's an application process, there is an active negotiation process, and we negotiate both the rates as well as make selection decisions about participating carriers. And then we've talked a lot in this work group also about the role of benefit design to parallel these other levels of selection and contracting to both extend ACA consumer protections to adult benefits, which are not considered essential health benefits and therefore are excluded from those ACA protections. We apply our patient-centered benefit design principles that we use on the health plan designs to our dental benefit designs. We believe in standardized benefit designs in order to support consumer choice that's really based on quality, network choice, and value. So we wanted to pause for a moment here and just make sure that our levers are clear to folks. We are really different from DHCS, for example, our state's Medi-Cal program. In that we are not directly contracting or reimbursing any providers. So Covered California operates through direct contracting with the plans, and then plans are managing all of their network, quality of care, provider reimbursement, provider payment mechanisms. And we are really engaging directly with the plans and then supporting that active consumer eligibility and enrollment function. Maybe I'll pause here and see if there's any question.
Hi, this is Monica with CDA. I had a quick question about the benefit design. So is that something in which there are work groups to discuss benefit design, or is that discussed internally at the board level to decide like what goes into that?
Thank you, Monica. That's a great question. And if Diane is available, or she can maybe speak to this in more detail, but our benefit designs are updated annually, and that is through a public stakeholder engagement process through our, I believe, plan management advisory meeting. I'm not sure, Diane, if dental has its own dedicated work group for benefit design.
No, we just discussed that during plan advisory.
Great, thanks.
Taylor, this
So,
is Jan.
Monica.
Can I add to that?
Thanks.
Too?
Yeah, thank you.
Yeah, this is Jan Falzerano. So annually in the fall, we would start our standard benefit design work groups, and probably in the late October, early November timeline is when we try to start those. But of course, it's dependent upon the release of the AV calculator as well as a notice of benefit payment and parameters. But we definitely talk about both health and dental. And so we definitely, if you want to be part of the standard benefit design work group, feel free to email us and we'll be happy to add you to the distribution as we start informing individuals of meetings that are coming up. Thank you, Taylor.
Thank you,
Okay.
Jan.
That's great. I do just want to put out there, since dental is so different, like we have attended some of those plan management advisory work groups, and obviously the majority is always focused on health plans. So definitely want to put that out there for Covered California to think about if there should be sort of a separate QDP plan management advisory work group. So yeah, just putting that out there.
Thank you, Monica. We are definitely open to that. We, in our early years, did actually maintain and facilitate a distinct dental technical advisory group. So if there is interest, if there's, we're certainly having lots of ideas generated through this contract refresh process. So we are absolutely open to maintaining a dental dedicated work group if there is interest and need among the parties. So thanks very much for that suggestion. If there aren't other questions or comments, I think maybe we'll turn. We wanted to take just a few moments and revisit our framework. We introduced this, I think, in April, but as we are coming back to a focus today, and we'll be hopefully in the weeds discussing our approach to health promotion and prevention, we did want to just revisit the framework, having just gone through kind of our role as a public purchaser. So this is how we are approaching our quality, equity, and delivery system transformation goals through our contract. So again, this is adapted from our health plan approach. Most of our domains are very similar to health plan. We have adapted some of the care delivery strategies we think are most central and supportive for dental care and oral health. And our goals are exactly the same. So no difference in our goals for health plan, health care delivery and dental care delivery. We wanted to kind of anchor here again for today's conversation because we'll be looking at potentially a number of different existing contract requirements that sit in very different articles across the contract, and really wanted to remind ourselves, but also open up the conversation today to think potentially really differently about how we've approached health promotion and prevention in the past. We are really excited for our guest speakers today to help us think potentially a little bit differently and more innovatively. And just a reminder with our key levers here, we recognize the significance of benefit design as well as some of the other activities that we could anchor in our contract, or we may be looking at activities or initiatives outside of the plan contract. So just want to be really clear and transparent with folks that we are open to all suggestions, both those that might be anchored in our contract or might be outside of the contract as well. If we go to the next slide, we'll just spend a moment on our principles for the contract refresh here on the left side of the screen, and then a reminder of our strategic focus areas. So we have spent our April meeting focused on the disparities reduction work, and today we'll be diving into health promotion and prevention. And as Tara mentioned, we are anticipating a focus in July on measurement and data. Again, we are really interested in closely aligning with the Department of Healthcare Services and the work being done in the Medi-Cal program, the Medi-Cal dental program. And we anticipate a real focus on data analytics and the new data coming in via our Healthcare Evidence Initiative, which is our claims and encounter data warehouse. Any questions or feedback there? Okay. Before we introduce our guest speakers, we did want to just take a moment and let folks know when we review our current, this slide could be a little bit more specifically labeled, apologies. These are the current existing contract requirements that we feel are supportive of health promotion and prevention. We are looking at some structural updates to how we organize the attachment 1 in the new contract draft. So we'll likely be updating some of these article titles as well as how we're organizing contract requirements, but did want to just briefly run through the kind of current approach here. So we do have an article, Article 2 is really focused on the use of data. So there are requirements for the plans to self-report utilization data. There are the requirements to begin submission of claims and encounter data to the HEI third-party contractor. Under our current contract, the use of enrolling health assessments is optional, but we do have some requirements for how the health assessment should be used if a plan is choosing to use them. And we have reporting requirements to report to Covered California the process used to monitor enrollees' oral health status, and that's both on an individual and population basis. We have a dedicated article for preventive health and wellness. And this includes requirements for enrollee outreach and monitoring, for use of preventive services, and some requirements for community-based activities to support health beyond an enrolled member population. In Article 4, we have requirements around supporting access, coordination of care, and support, identification and support for at-risk enrollees. So we have kind of an open question about this role of the primary care dentist or a dental home in both DHMO and DPPO models. We're really interested about how to get folks into initial care appointments and then emphasize continuity of care. And then finally, Article 5 includes requirements for making available cost and quality information for network providers, pricing information for high frequency or high cost services, and requirements for real-time availability for members to know the status of their benefits, care received to date, and then the various types of out-of-pocket costs depending on the plan they're enrolled in. So we wanted to set the stage a little bit as we learn from our guest speakers and just again be very clear that this is all on the table in terms of how we establish and organize contract requirements that will support our members' health, starting with preventive care, but making sure that they're able to access all of the care that they might need once they're under the care of a provider. I think if there's no questions or comments on current contract requirements, I'll turn it back to Tara to introduce our guest speakers. Thanks.
Thank you, Taylor. Great. So before moving on to our guest presentations, I wanted to take a moment to provide some background on our speakers today. Our first speaker today is Dr. Paul Glassman. He is the Associate Dean for Research and Community Engagement at the College of Dental Medicine at California North State University in Elk Grove, California, and Professor Emeritus at the University of the Pacific Arthur A. Dugoni School of Dentistry in San Francisco. Dr. Glassman has served on many national panels, including the Institute of Medicine's IOM Committee on Oral Health Access to Services, which produced the IOM report on improving access to oral health care for vulnerable and underserved populations. Dr. Glassman is a pioneer and has led the national movement to improve oral health using telehealth connected teams and virtual dental homes. He has been prominent in the advocacy efforts on a state and national level for health system reform to improve oral health systems for a wide variety of underserved groups, and we are thrilled to have him speak here for us today. Next, following Dr. Glassman's presentation, we have our second speaker, Dr. William Jackson, who is currently the co-founder and COO of Virtual Dental Care Inc., a telehealth technology company founded in 2016. In addition to practicing clinical dentistry for 10 years, Dr. Jackson created a small Knox-Keene licensed managed dental plan, which was acquired by Prudential Healthcare. He has served as president of Prudential's dental division and was hired by WellPoint Healthcare Networks to run their national dental division, both of which he had P&L responsibility over. After leaving WellPoint, he started Dental Connect Inc., the industry's first real-time dental claims clearinghouse. The company later merged with Dental Exchange Inc., which grew to the largest real-time clearinghouse in the industry. And upon the sale of Dental Exchange in 2004, Dr. Jackson helped start Planet DDS Inc., which is the company that created the cloud-based dental practice management software Denticon, which is focused on the needs of DSOs. Dr. Jackson then exited Planet DDS after its sale in 2016. So we value and appreciate the wealth of knowledge and background both speakers bring to their topics today and welcome them to the work group. With that, I'll go ahead and hand the floor over to Dr. Paul Glassman on an evolving oral health industry, and I'll go ahead and stop sharing so that you can share your slides, Dr. Glassman.
Great. No, thank you so much, Tara. So let me go ahead and share and assume you're seeing my slides now. Is that correct?
Yes, I can see
All
them.
right, very good. Well, again, thank you so much for the invitation to be here, and I appreciate Taylor's introduction a few minutes ago about one of the goals of today is to try to think a little bit differently about dental care and dental health. And so I know many of you are very steeped in the things I'm going to talk about, so it may not seem so different to you, but I know for in general, people in the oral health industry, that some of the things I'm going to say are different ways of looking at oral health care, oral health access, and particularly oral health. So I'm going to start out with a little bit of a historical perspective on the health systems in general, and then bring that into oral health, and then lastly finish up with some suggestions and ideas about how some of these trends and evolving ideas might be incorporated into the covered California activities. So start out with a little bit about this road from quality to value. I'll tell you what I mean by that in just a moment. I think if you haven't been following this, or maybe you don't have as much gray hair as I have, and you weren't around in healthcare or working actively in it in the 1980s and 90s, what you might not be fully appreciative of is that there was a big change in thinking about healthcare in the 80s and 90s, where the idea of quality became very prominent. Um, there was two major reports from the Institute of Medicine, this one on To Err is Human and then Crossing the Quality Chasm, that really brought into the forefront of national thinking the idea that our healthcare systems need to do better in terms of quality. Now, some of that was centered around the idea of not making medical mistakes. I use the example of when someone comes into a hospital and they've got a appendicitis, you don't want them to fall out of bed and break their hip. That's clearly something that shouldn't happen. So now there's obviously less dramatic examples, but the idea was there began to be a big focus on quality of healthcare, pretty much focused on not making mistakes and not making things worse when someone was within the healthcare system. So that evolved to a really big focus on measurement. And there began to be initially a big focus on quality measurements. All kinds of data began to be collected. That led to a focus on what was called quality assurance, which was kind of the checklist mentality. And checklists are still in use today and very important. But the problem with checklists is it assumes that you know how things are supposed to be done, and then you measure people's activities against, did they do what you think they should have been doing? But that soon gave way to the idea that, well, maybe we don't know everything about how things are supposed to be done, and maybe there's room for innovation. And that changed into a focus, which we have a large part today on quality improvement, that we need to be in our healthcare systems continually improving, measuring, thinking about how the outcomes, thinking we do something better, and then remeasuring. So I think probably you're all familiar with the idea of continuous quality improvement. But another change in this road came about in 2006. An example, this guy Michael Porter, who was a big name in the business community. I got an MBA, and half the case studies I did in my MBA program are written by him. He said, "Well, look, it's not enough just to measure a lot of stuff. There are some things that are more important to measure, and that's particularly value, which he defined as being related to health outcomes." So he pointed out that process measures are important, but they really aren't any substitute for measuring health outcomes, and really began to say we have to measure kind of the outcomes of our systems, not just did we do a lot of stuff, but what good did it do? And that even got taken a step further in 2007 by this guy, Don Berwick, who was at the Institute for Health Improvement, saying, yes, it's important to measure health outcomes, but there are a few health outcomes that are even more important than other ones. And this has become sort of a national mantra for our healthcare systems in general, that we need to be really careful about focusing our activities on improving the experience of care, improving the health of populations, and reducing the per capita cost of healthcare. I could talk a lot about all those three things, but I don't have time to. But the one I just want to emphasize is improving the health of populations. That's a really important concept, and I'll come back to it as in my little bit of time that I have here, because I think previous to that, a lot of the focus was on the care of an individual interacts with the healthcare system. Are they better off after they interact with the healthcare system? But now he raised the idea of we also need to think about the health of populations. The triple aim has since been reconfigured to include the quadruple aim, because people are saying it's in addition to thinking about the experiences of patients getting care, it's also important to think about the experience of providers. So all that began to sort of shift our thinking about our healthcare system. And then in 2010, this idea came up from the Urban Institute that it's okay to think about we want different kinds of outcomes, but unless you start to pay for things that are directly related to those outcomes, you're not going to get them. It's one thing to give lip service to them. So they came up with this idea of moving payment systems from volume to value, meaning if you're going to actually want a system that produces value, you've got to set up the payment system so that that's what gets paid for. So that was a very quick little health systems, big picture, what's going on in terms of the shift from quality to value to payment systems. So let me just take that idea and focus for just another couple of minutes on the oral health industry, or sorry, on what's actually happened in the U.S. healthcare industry that relates to that. And I think probably people are aware of the data here from the Commonwealth Fund. The red line is the amount of money we spend as a percentage of our GDP in the United States compared to all the other developed countries in the world. And you can see at a glance that we spend a lot more money on healthcare than all the other developed countries in the world. And yet, when you look at what we get for all that money, it's not so great. So the Commonwealth Fund has these charts that are talking about this is an overall measure of performance in our healthcare systems. You can see all the other countries kind of clustered together. You can see the United States is a huge outlier, both in terms of the amount of money we spend and the quality of the care and the outcomes of the care, and not in a good way on both of those measures. And they have a lot of other measures. I won't bring them all up here, but just in terms of the same kind of thing, when you look at affordability, United States last. You look at equity in terms of who's getting care, United States last. And when people analyze, why is that? Why do we do such a poor job? What often comes out is what's depicted here in this diagram, which is that we spend a lot more money on very expensive things that tend to benefit smaller numbers of people than other countries do. We spend less money on outpatient physician visits, as depicted on the bottom of this chart here, a lot more money on MRIs and bypass surgeries and other kinds of very expensive things. So it's pretty clear we spend our money differently than other countries, and that's also illustrated in this chart here that from the Commonwealth Club. Right in the middle is the United States, and the dark blue, the light blue is how much money we spend on healthcare. Healthcare is stuff that happens inside the healthcare system. So you can see at a glance, the United States, that bar is sticking way up above the others. But I think even the most interesting thing in this is the other side of it, which is social care. And this has to do with what is commonly now talked about, the social determinants of health. And you can see the United States spends way less than the other developed countries on those social determinants of health. So most of our money goes into healthcare, and most of our money goes into complicated and expensive things that benefit not so many people. So let's think now about how does all that relate to what's going on in the U.S. oral health industry. Well, first of all, just overall utilization. We've made some modest gains in utilization over the last decade or so. And you can see that the highest utilizers of dental care are children 6 to 17 years old. But this data lumps everyone together in terms of economic strata and all kinds of other variables. And if you start to break that out, what you can see is that this is combining on the left side children, middle adults, right side seniors. There's a huge disparity based on how much income you have, so that lower income people are much less likely to interact with the oral health system than people with higher incomes. The same thing comes out in this data when you look at, this is different points in time, the 3 different bars, but on the left is low income people, on the right is high income people. The previous slide was about access, and this slide's about disease. And again, it doesn't take a great analysis to look at, the bars are much bigger on the left side, which means that lower income people have much higher rates of disease than higher income people. And so the conclusion from all that is that we have a U.S. oral health industry that's primarily serving the wealthiest and healthiest segments of the population. It's not that no low-income people get any care, but primarily the people who are accessing dental offices and dental care are higher income people, better educated, have actually less disease, and the people with most of the disease are actually not taking advantage of care in the current way the dental industry is set up. So what do we do about that? And that vision, I'll list the golden rings just to attention and wake people up. So I have some golden rings around these 3 circles, but it's really the words in the 3 circles that are critical. So I think that the path forward towards producing a more equitable, affordable, and effective oral health system are these 3 things, which is measurement, payment, and incentive systems, the use of modern prevention and behavior science, and modern delivery systems. So let me say a little bit about each one of those. Measurement and payment systems, obviously that relates a lot to what we're talking about here today. We're talking about a opportunity that Covered California has to influence the way things are measured and paid for and what kind of incentives. And there's a lot of people in the oral health industry that are hard at work looking at measurement and payment systems, everyone from the Dental Quality Alliance, and I understand a lot of their measures are going to be used by Covered California in developing incentives for the dental coverage going forward. Lots of payers, so some of you in the dental benefits industry are already well immersed in this idea of collecting data and what you should measure and how to use it for incentives. And the HRSA health care system is pretty far ahead of the rest of the country in this, and as well as group practices. But I think that the most interesting point I want to make about these kind of measurement and incentives is that initially they were really focused on this idea of what happens inside a given dental office with a given patient. That's what all the measurement has been about primarily. And now we're seeing a really significant change in focus to, hey, we shouldn't just measure the outputs of people that go into an office. What about the health of the community? Now, I do a lot of speaking and I talk to many dentists about that. And often when I get the response is, whoa, now wait a minute. Now, I can't do anything about the health of the community. I have this office and people come, they see me and I do what I can for them, but I can't control what happens when they leave the office. I can't control the people that don't come to see me. So what can I do about the health of the community? Well, the point I want to make in the next few minutes is we actually have the tools, the understanding, the know-how to actually do better at improving health of communities. We have lots of structural policy and other barriers to being able to put that knowledge into place, but we actually know how to do it. So let me give you a few examples of some things that we have in our toolkit now that can actually begin to shift our oral health systems towards improving the health of communities. So one is the advent and use of modern prevention and behavior support science. So I'm assuming everybody on this call probably knows what I'm talking about. We're talking about things like remineralization and buffering agents and caries arresting medication and science about sealing caries, specifically fluoride varnish and silver diamine fluoride, which if you don't know that, it's one drop of this liquid can stop the progression of decay for many months at a time. The ability to actually seal caries in teeth without having to remove them all using sealants or interim therapeutic restorations. But the reason I'm bringing these things in today's talk is that these are all things that can make a big difference in people's health, but they don't have to be done by a dentist. They don't require any local anesthetic injections. They don't require any dental drills. They don't require a dental office. They don't require a dentist. These are all things that can be done by allied personnel in a place like a school or a Head Start center or a community center or a nursing home. And so it's just a spectacular difference in just our technology to be able to do procedures that can help people improve their health without needing all of the complicated and expensive things that are part of the surgical suite, which is what a dental office is, all the expensive equipment and sophisticated technology. A lot of things can be done now in community settings. The other part of that, this golden ring, was prevention and behavior support science. And so I want to just quickly mention that we know a lot more now about absolutely the most important thing in having people have good oral health, absolutely the most important thing, which is what people do by themselves for themselves every single day. Much more important in terms of people having good oral health or not than anything a dentist or a dental hygienist or a dental professional is going to do to them. And so what we understand now is that people are much more likely to adopt what I've been referring to as mouth healthy habits if there's messages are delivered by people that they see as culturally congruent, trusted members of their own community, people who they see having similar life circumstances as they do. Now, of course, it's helpful when multiple people deliver the same message. But dental offices and dentists and hygienists are not that effective at supporting adoption of mouth healthy habits for a number of reasons. First of all, most of the people who need that kind of support aren't even getting care in dental offices, so there's no way to influence them. And then the people who do end up going in don't go often enough to be able to do the important things in the bottom of this list of bullets, which is suggesting small incremental behavior change, ongoing reinforcement and coaching for that kind of change, peer support. All that stuff is really the key ingredients to having someone adopt mouth healthy habits. And I don't have time to talk about some other examples of this that I normally do, but if you just think about your own self and what kind of habits you have and how difficult it is to change them, you can realize that starting with a small change, getting some reinforcement, someone's paying attention to you, ongoing coaching, that's what's going to get you to change that habit. And so that leaves the conclusion that we're much more likely to get people to adopt mouth healthy habits if we can begin to integrate oral health services in with community organizations, with people who are in touch with the target population on a very regular basis. Okay, so last of the golden rings is delivery systems. And I'm going to focus specifically on teledentistry for the moment. So we know that teledentistry has gotten a big boost in awareness during the pandemic. Mostly it was someone broke a tooth and took a picture and sent it to the dentist, who provided some kind of response. Sometimes it was don't worry about it. Sometimes it was come in and make an appointment. But that has led to an increase in people realizing the potential for connecting patients with dental offices using teledentistry for pre-operative appointments, post-operative appointments, updating health histories, registration, a whole bunch of things. And so there's an increasing use of teledentistry-based systems for these kinds of things. But as we get more sophisticated in our use of these systems, what that opens up is the ability to connect with the community. So an office that has actually mastered the teledentistry technology now can begin to interact with the community, and they can do that in many ways. But the one thing I want to just mention here is the example of doing this in a way that I call full service care. And this actually turns dental care on its head in terms of the way it usually operates. Typically, dental care that has anything to do with the community, the idea is to identify people in the community and then get them into a dental office. We call the dental office the physical dental office, the bricks and mortar facility, we call that the dental home. But what we have the opportunity to do now is think differently about it. We have to think about this whole thing, the office, the community, the telehealth connection. That's the dental home, or I've been using the term virtual dental home. And in this kind of system, the idea is keep people healthy in the community. If you can keep children healthy at their school without needing to make a trip to the dental office, everybody is better off. I'll show you a little bit of data in just a second about that. So the point of this idea of this slide, full service dental care, turning the operational incentives on its head, try to keep people healthy in the community, use the dental office only for the complicated services that have to be done in that environment. And now we're seeing companies that are beginning to build on that, to begin to look at connections between offices and communities using telehealth systems to produce networks of telehealth. And you're going to hear a little bit more about that from my co-speaker, Dr. Jackson, in a moment. So I'm calling all of this advent moving towards what I call community engaged oral health systems. This is the idea that the focus of oral health becomes the community. It becomes the connections of all of the community organizations, people in schools and Head Start centers and nursing homes and community centers and all those kind of things, trying to keep as many people healthy in the community and using the dental office, which is an integral part of the system, but using that for the more complicated things that need that environment. So I only have one slide because I don't have time to talk about it more, but an example of that kind of system is the virtual dental home. I've been working on that for close to several decades now. And it's a system that uses hygienists and assistants going into all the different kinds of sites that I mentioned, and being able to keep as many people healthy in the community as possible. So we did a 6-year demonstration of this system, and we're able to show that, particularly with children, we could keep 2/3 of children could have all the care that they needed in the community, in the school. And that was before we had silver diamine fluoride. So we're now estimating that we could keep 85% of children healthy at school. Now, if you think about that for a second, that's an astounding difference to what happens in our system now, where most, particularly low-income kids, don't get any care at all until they have lots of disease and lots of problems and end up in the emergency room or even the hospital. To be able to keep 85% of those kids healthy at school by getting to them early and applying these preventive strategies we have, it's a really big deal. So I'm suggesting to you that the path towards value in oral health is really this idea of community engaged oral health systems. Let's start to figure out how do we get our dental offices connected with community structures that can really add all kinds of value to us producing value in oral health. And so I'll just finish with a couple of suggestions about how this can work within the Covered California system. And as Taylor pointed out at the beginning, and I hope I didn't distort it by summarizing it here in these bullets, but the levers that Covered California has, they're not directly paying for care, but it can be in developing plan criteria or structure, how the plans actually work. It can be in performance metrics and incentives that are put out there for plans and providers to do certain things that meet those metrics and incentives. And it could also be in training and support for plans and providers, which could be provided at the Covered California level, could be provided at the health plan level. So with those three potential levers, let me suggest a couple of things that could make a difference to get to some of the things I've been talking about within the Covered California system. So the first one is, and I believe, although maybe some of you will tell me it's more complicated than I'm thinking about it, but I believe a relatively easy thing that could be done is for plans in this system to say that they'll allow payment for care provided regardless of the delivery model. So if someone does a preventive procedure, or they do one of the other preventive procedures that can be done in the community that I talked about, the plan's going to pay for it, whether it's done using teledentistry, whether it's done by a hygienist in the community, whether it's done by the dentist in the office. It'll be a relatively, I believe, simple thing for plans to build into their design, that you're going to pay for the care no matter how it's delivered, and allow providers to take advantage of the new opportunities I've just been talking about. A second possibility is to organize and support community care systems. So that's a little bit more of a lift. That would involve some more complicated things in getting some kind of a system built. It would probably work better in some of the plans that are offering HMO style plans rather than individual purchased plans. But there might be a possibility of organizing some kind of community care systems like I've just been mentioning. And then I think that for really any of the providers, if it would be helpful if they had some kind of training and support, both for the plans and the providers, about innovative delivery systems I've been talking about, and how they can actually be supported in delivering care using some of these new systems. It's really clear that I said it earlier, that we have these things, that we know how they work, we know that they work, but there's a lot of unawareness. Negative way to say it. There needs to be more awareness, I guess is a positive way to say it, about these things. And I think for the foreseeable future, there needs to be training and support if we're actually going to take advantage of this. And the last bullet to think about is support for technology-based patient engagement, which has become a huge deal in the healthcare industry in general. That technology-based patient engagement is producing all kinds of spectacular results. And with that, I'm going to turn it over to my co-presenter, Dr. William Jackson, to talk about that last bullet point about technology-based incentives and ways of engaging patients, and then look forward to talking with you all during the Q&A in a few minutes.
Thank you so much,
Taylor,
Dr. Glassman.
back to you, and I'll stop sharing.
All right, thank you, Paul. That was a nice lead into what I'm going to be talking about. So Taylor, you have my, I'm sorry, Tara, you have my slides?
Yes, let me pull them up real quickly here. There we go.
Great. And you can go to the first one. And there's a little bit of editorializing here, but I do think that there's going to be technology that can certainly increase access, the stuff that's being used now, and focus on individual needs, ultimately getting better community results, as Dr. Glassman was just talking about, but I think we have to focus on the individual. And then this is a little bit of editorializing. I do believe it can lower the system-wide cost of care. It certainly doesn't necessarily have to increase it. And I have to admit, teledentistry is not a word I like anymore. Everybody has a different idea of what it means. And, you know, it's for most, and this would include most dentists, they think of FaceTime or Zoom. When it's, to me, it's a much bigger world of communications. It's communication, yes, between provider and patient, that provider being a dentist, it might be a physician, it might be a nurse, it might be a hygienist, but it also is collaboration. It's a community of individuals, teams of individuals that can communicate together with common records. And I'll talk a little bit about that in the time that I have. I could talk an hour on that alone. But if you go to the next slide here, that'd be great. So I kind of put this out there as the ideal, and that is that if the individual or parent or caregiver is always 100% aware of your oral status, it's going to be pretty easy to know when you need to have care and what that care needs to be. If you're healthy, great, then let's do activities that'll maintain that oral health. If you need treatment, then let's make sure you receive the necessary care and its quality and so on and so forth. But what does that require? Well, it requires individualized awareness of everybody. You need to know it yourself to know when to seek treatment. And also, you're only getting treated when you need it. And the next slide, which you can go into, Tara, now, and individualized wellness. So the current way, and it's been this way for 70 plus years, is how do you assess your oral health? Well, you go into a dentist twice a year. And is that, where did that number come from, by the way? I was told in dental school, I don't know if this is true or not, but I was told in dental school that it was a Bucky Beaver. If anybody's old enough, maybe Paul, you might remember, but that's it was a Ipana toothpaste many years ago, and their icon was a beaver. Bucky Beaver, and the commercial was brush your teeth twice a day, visit your dentist twice a year, and that's where it came from. And the insurance industry picked that up back 70 plus years ago. Obviously, there's studies that show there's an advantage to doing that, but the advantage is you'll know your oral health status when you go in twice a year. If you don't go in, you don't know your oral health status, and so that's really a big point of failure right there. Is patient-initiated participation. Plus, do you really need it twice a year? Well, no, of course not. Some people probably need less, others need more. So having this one size fits all 2 times a year doesn't make a whole lot of sense either. Again, the whole force of this goes through the dental office. And it's the dentist that makes the decision. Are they healthy? Yeah, give them a toothbrush, send them home, give them toothbrush instructions and so forth. And that's kind of about it. I do have a continuous feedback here, but yeah, you get your postcard once every 6 months that says time to see the dentist again. But there isn't a whole lot of continuous feedback there. And certainly after treatment, is there continuous feedback? It sort of depends on the dentist and the dental office, but generally speaking, it's see you in 6 months is the continuous feedback that you get. And so again, lots of points of failure, but there really wasn't much any other way around it, I should say, for how long. You had to go in, you took the professional to assess it, and treatment was going to be rendered accordingly. And assuming that treatment was the proper treatment, then everything went well. Okay, if you can go to the next slide. So now the first point of failure, and this is one of the bigger points of my talk today, is okay, why don't people go to the dentist? Because this all falls apart if you don't go to the dentist twice a year, right? So why don't they go to the dentist? There's studies on all of these. I didn't want to waste a lot of my time. It's pretty intuitive to not put up stats, but people aren't going in because of safety. The last study I think I saw was as high as 20% of people are still fearful of going into a dental office because of COVID, even though it's one of the safest places you could possibly go, but the patients don't know that. Fear of pain. There's also the unknown, and it's been 2 years, 3 years, 4 years since I've been to a dentist. I don't know what's going on. I think I'll just keep my head in the sand. If I don't find out, then there won't be a problem. So there's that fear too. Cost is always at the top of the list. Time, I'm either too busy, or if nothing really is hurting, I can just put it off easily enough. And of course, physical access. Okay, you can go to the next slide, Jeremy. So now all these things are floating around out there. I know most of the payers, I would assume on this call, are already using teledentistry on some level. But there's still a lot of pieces floating around that are going to become centralized, and companies like ours are already well along in being able to offer these right now. And I could talk an hour to each of these. I will talk a little bit about the ecological momentary intervention. That's a behavioral science term that I think we can bring into dentistry quite effectively, and the technology's there. Artificial intelligence is going to change the landscape, and I'll talk a little bit about it, but I think it's something we all ought to be aware of it. The at-home risk assessment tests are on the horizon. We already have 2 customers, for example, that are going to work with remote networks of dentists where the patient is at home, maybe doing a saliva test, or there's other types of things they can do risk assessments, and then in consultation with a dentist remotely review those. Remote peer-to-peer collaboration, I really don't have enough time to talk about it today, but there's lots of technology, and again, certainly something our company offers. Inexpensive imaging devices and easy access to secure patient records. That's all here today. And if you can go to the next slide, I'll talk a little bit about how it's all coming together. So really, what do I mean by teledentistry technology? Well, it's all the communication channels. Again, it's not just video conferencing, which again, most people think is all the teledentistry is about, but there's recordings and text and chat and email and voice. We all know that dental right now is still mostly voice. I mean, I'll get an email to remind me to come in, or a text to remind me I've got an appointment, but nothing that's using the sophistication of where technology is today. And what does a good communications platform? Again, I'll say teledentistry, but teledentistry, but tele just means remote. So it's remote care. But you do need something that brings it all together, that coordinates, organizes, documents all the communications, and allows the patient to have access to that all that information. You're going to need an electronic health record that integrates with other PMSs and practice management systems. And again, the technology is already out there today to do these kinds of things. So let's just walk through the next slide, if you would, Tara. And then the next of how this could potentially help. So let's talk about patient outreach. So I mentioned using text and behavioral science. For pennies a year, we can use text to outreach and communicate to patients in these little ways. I mean, maybe I got a text that said, did you know that 27% of all patients don't see a dentist because they're afraid of pain, or whatever. I don't, we are working with some behavioral scientists right now to come up with what these cues should be, but maybe just once a month or once every other week, just something to begin to modify behavior, like Paul was talking, Dr. Glassman was talking about before, and then give them a call to action, give them something to do with it. And maybe that is click on something. If you can go to the next slide, Tara, that'd be great. Give them a way to maybe upload photos. So this is an example of something that we have for our company, but there are others out there. And I know that some of the payers are already offering this as a benefit to their members. But again, use it as the second step, not necessarily the first step. Don't require the patient to download an app and to do this all on their own, but remind them maybe with these texts and behavioral science reminders. Let them take these and upload these. They don't even have to go to the dental office at that point. So it answers the question is, do I have anything wrong? It's been 3 years since I've been to the dentist. I'm afraid to find out. Well, I can do this at home. I don't necessarily need to go into a dental office to do this. And if you can go to the next slide then. And there's all kinds of devices that are hitting the market already. If it's a little bit more difficult to take that, maybe you're a caregiver, or maybe you need to do this on a child that's squirming, or maybe you need to do it on an adult that has dementia. So there's devices that'll help take that. They're all hooking to the, as you can see, to a mobile device. This is hooking to the phone. And these are pretty good photos to be sending. And again, this could all be done from the convenience of home. You can go to the next slide, please. And not too far, we are already in discussion with several companies that are doing AI with those photos. So that maybe the first scan is nothing more than the patient, the member taking those photos and them being, again, organized through a teledentistry platform and getting feedback on what the status of their mouth is. So that it is, yes, you do need to see a dentist, or we recommend, our attorneys would not like the words I'm choosing, but just to remind them that, yes, it's important for you to see a dentist and give more information based on this. Have a risk assessment immediately available to that patient. That patient could do this once a month, so that, again, they have that knowledge in their hands. And this is for pennies a day. This is really inexpensive technology that allows the kind of information that I've got below: cavities, gum disease, gum recession, gum disease, obviously, if it's visible above in the photo, et cetera. But again, this is even before they've talked to a dentist even. And then you go to the next slide. Again, there's the in-home testing that is hitting the market, and is two companies that, again, are customers of ours right now, getting FDA approvals on some of these testing. You can go on to the next slide. And then if the patient wants, then you can even have a video conference. So, well, I had this photo taken, the AI, and again, I'm just using AI, or I was told from the feedback that I got that I should probably talk to a dentist about this problem that I have. Let's just talk. And the dentist can review if there's any specific questions or any problems. They can be dealt with there. And then from there, they can be, if necessary, they can be referred to an in-office a dentist, and in our case, to actually in-network dentists if this is plan specific. Okay, you can go to the next slide. And here's the kinds of referrals that certainly we're doing. Again, we're not unique in this, but there's a few dental networks out there. We're a little unique in how we refer to the in-network providers, because we actually share the patient record with the in-network provider. So if I had a conference, and we do have a DSO of remote dentists, our company owns a DSO that will take on-demand calls. So all the data that's gathered on that call, be it from consent forms, health history, what was talked about on the call. If it was a video call, we can even see that they could see even the video, the dentist that's getting the referral, if a prescription was written and so forth. All of that can be shared with the dentist for continuity of care purposes. This is a tremendous plus. Okay, you can go to the next one. So let's just look at how this flow might go. So patient outreach, and again, there could be communication sequencing with, again, this behavioral science communications, I'll call it. But essentially, it's kind of a CRM, right, with artificial intelligence attached to it. So I can change my messaging depending potentially on the disease state of the patient, or whether they've accessed care or not, and so forth. So that capability is out there now. Okay, so then a call to action. So I get this text, and yeah, I really do want to find something out. I can click on it, and I can submit photos for professional review. And as I say, AI assessment is somewhere down the road, not very far. I could click on talk to a dentist now. So again, with companies like ours offering on-demand appointments, I can schedule a video conference if I want to schedule it, as opposed to talk to a dentist now. Or again, through applications like ours, they can actually schedule or request an in-office appointment, would be a better way of saying it. And we can communicate with in-network dentists that somebody has requested. So all of these are available, just lowering the bar of access for these patients that require care. And again, this is putting the power in their hands and lowering, the fear aspect of it. They're doing it from home. The cost aspect of it, if it's through a benefits plan, it's probably going to be at no cost to them. It's convenient. They're not losing time from work to do this, and then they'll know in advance if they do have to schedule an appointment for certain stuff. And literally, they can. And this is going to come out of AI. They could literally take once the companies get a FDA approval for AI, they could take a suggested treatment plan into the dentist, or have that sent to the dentist. Okay, if you can go to the next slide. So let's say I do the photo review. Well, I can talk to a dentist now, because now I see this tooth looks really black. It really must be a problem. Or I can schedule a video conference if I want. Or again, I could just send that data and share that data with an in-network dentist for the different plans, and they could see it in advance, and they can have access to that record. And higher end companies are going to have electronic health records like ours that can integrate with practice management systems at the dental office level. Okay, you can go on to the next one. So once I talk to the dentist or schedule a video conference, and I get that in-network referral, then I do want access to a common record for everybody. And this doesn't have to just stop with dentists too. So we're definitely in discussions with making that healthcare team bigger, that have access to these records too, be it a physician, a nurse, a home healthcare worker, a hygienist, all who have the ability to use all of the communication tools that I talked about, be it text, chat, email, video conferencing, video recordings, all of it put into a common electronic health record that the patient has access to also. And the patient can download those records and take it to other providers if they so choose. So I'm going to stop it there, just because, again, I could talk for hours on any of these topics. But the whole idea was just to show that this stuff's there now. This is not futuristic. AI is not quite, but it's is very, very close. And our ability to put treatment choices into the hands of the patients is there now, and our ability to access patients is considerably higher than it ever was. And it doesn't have to be the dental office that reaches out, or somebody just suggesting via a postcard or a telephone call that, gee, it would be a good idea for you to go to the dentist. So I'll just stop it there, and let's let you move on, Tara, with the question and answer, I guess.
Thank you so much for the wonderful presentations. I'll go ahead and open up the floor to participants with any questions or feedback that you may have on the presentations.
Hi, this is Monica with CDA. Great presentation, Dr. Glassman and Dr. Jackson. I was curious, Dr. Jackson, you were talking about how these technologies, some of them are already here. And so I was wondering if you could speak to, with these innovative technologies, are there higher utilization rates than you would see otherwise than in a traditional office?
Oh, this is also new. That's data points that I don't think anybody has access to at this point. I think logically, you would see higher access. If once again, if I know as a patient, and I've even talked with the dentist that I'm going to go see, that I need care, you would expect it to go up. But so you would probably see utilization of certain procedures go up, but you would probably see the utilization of other procedures go down. Twice a year cleanings, as I say, is probably not necessary for everybody. But I can't assess that without looking at a patient's mouth. But one would assume that utilization for cleanings and exams would probably go down, but certain other procedures might go up.
And I can just add something to that. No, thanks for the question, Monica. That certainly not as sophisticated as some of the things that Dr. Jackson just showed, but in the work that we've been doing for 20 years of having someone like a dental hygienist be in the community with schools. And we have there's overwhelming data that we're able to keep a lot of kids healthy. You saw the numbers before. It could be as much as 85% of children healthy at school. But we're talking about children who are traditionally not getting any dental care. So it's it doesn't take a sophisticated statistical analysis to know when you're going from 0 to 75% that you've gotten more kids into a dental care system. Particularly, we're talking about lower income children or the majority of people in our population who don't access dental care on a regular basis. There's no question we can dramatically change the interactions with the dental care system by some of the things that are being talked about here.
Great, thank you.
I don't see any hands raised or other questions, Tara.
Okay.
Sarah, I was gonna, before we move to ours, I had a bit of a follow-up for Monica, which I think raises a really important question around how might quality measures need to evolve if we're able to, if we have less of a one-size-fits-all utilization sort of rubric, and is that work underway by measure stewards, or are there other ways, again, particularly with our purchaser hat on, are there other ways we might need to think about how we assess utilization from kind of a right fit or, health assessment perspective?
Mm-hmm. So in thinking about, I want to make sure I understand your question. So in thinking about sort of the best way to measure like the health, sort of the second question here, the health promotion and prevention piece from the provider perspective, is that the question?
Actually, sorry, I didn't mean to direct it to you. I'm happy to, if you have thoughts or updates, definitely would want to hear from you. I meant more just tagging onto your question for Dr. Glassman and Dr. Jackson about utilization, changes in utilization levels, and how that might then impact how we think about, what is the right amount or the right kind of utilization.
Yeah, no,
from a
Ted,
measurement perspective.
I can say a couple things about that, which is that I'm not sure we need dramatic changes in measures. You know, the Dental Quality Alliance has a pretty good set of measures. They might need a little bit of rethinking. Some of them are more oriented towards what a dentist does. And so I think as you're developing measures, you might want to think about did that thing happen regardless of who did it or where they did it, which is one of the recommendations I made. So that might be a change in measures. But I think the more significant thing is there are lots of well, just examples of incentive systems in oral health that didn't go so well because a set of measures was was proposed, some incentives were proposed, and the plans and the providers really had no understanding or ability to be able to actually perform on those measures. And so I think that it's important to think about when you're putting out measures and incentives, what's the system that's going to allow everyone to be successful on those measures? And it's not the traditional oral health system. We just know that we know the limits. We've been trying to tweak around the edges of it for so long. And so that's when the idea of thinking differently, if we're looking at health measures, if we're looking at access measures, if we're looking at measures of the use of preventive procedures, all those things which are in the traditional list of measures, I think the real important question is how do you help and support people to actually be successful? And I think it's just going to take a lot more than saying we'll pay you an extra 5% if you do this, because you also have to build in how do you help people and make sure they have the information, the structure, the technology to be able to actually perform. And as I said, and I think Dr. Jackson showed, we have that information now, but it takes a rethinking of the systems and a training and support to be able to perform better on those measures.
I'd add, build on that. It's sort of putting on my old insurance executive hat here is utilization measurements are really were nothing more than a surrogate for quality assessment, and we might want to rethink some of that. So again, the two times if you going into a dental office more doesn't necessarily mean that they're going to be healthier, but that would be a utilization statistic that historically would have been measured to determine. So I think as we begin to take a look more and more at what utilization stats correlate better with healthy outcomes, I think that they do probably need to be jiggered in the future as to what utilization measurements are important and which aren't.
Thank you. So I added in this additional slide here at the end to restate some of the questions we had sent out prior to the meeting today. And going forward, we will do that again for the July meeting, and we will get those out a little sooner than we were able to for this month. But I wanted to give participants a moment to look them over again or give you all the opportunity to provide some responses or feedback to these questions if you're able to sit and digest them and think about any feedback you may have for us, and then definitely following our presentations today if you had anything additional to add.
Hey, Tara, this is Kristen with Delta. These are great questions. These are exactly some of the topics that we were discussing internally. We don't have a response today, but I'm definitely going to note these and we will provide something soon because these are hot topics for us that we want to talk to you guys about.
That's really good to hear. Thank you. I can also send out an email survey to the group with these questions again, if it helps to remind folks that feedback on these topics is greatly appreciated.
Hi, Tara. This is Monica with CDA. Definitely appreciate you sending these questions ahead of time. We did discuss these internally, and some of these responses we will send to Covered California early next week. I did have a question on the last bullet point here regarding the feasible starting points. I was wondering if you could if there could be some more clarification or potentially like examples of what you really mean by the feasible starting points here.
Sure. I think, Taylor, are you able to jump in and help with this question?
Yeah, if that's okay. And would certainly invite others to my kind of thinking around this question is, for example, we have provisions in the current contract around the use of oral health assessments. We don't currently require, but then we say if you contractor do conduct oral health assessments, we think it should be, administered in this way. It should result in personalized feedback to the member, like those kinds of provisions. We have talked a lot about, and we'll talk certainly in future meetings more around, the importance of data sharing and providers sharing data with plans, and then submitting it to Covered California. So understanding the feasibility, I think, element here is like kind of where is the right minimum bar potentially to set by contract versus are there other other activities that we could be engaging in or issuers could be engaging in outside of a contract. So kind of really understanding how to use our contract appropriately to achieve what we're trying to achieve, and particularly in the area of trying to move kind of beyond common or historical approaches. I've been thinking a lot since our last discussion about Dr. Glassman's comment about health literacy and this assumption that like if we just share information and we're sort of operating in a vacuum of not acknowledging other dynamics. So as we try to think a little bit differently about how to get folks into care and understand the type of care and the amount of care they need, how do we approach setting some of the right contract requirements for plans, or what types of activities go in a different bucket than the contract?
Okay, great, thank you. And I definitely appreciate that clarity.
Okay. So thank you, Taylor, for the explanation. What I'll do is I'll go ahead and send an email out to the group with these questions again, and give folks some time to develop responses. And we look forward to hearing from everyone, both on this and of course the previous topics that we've had. If you still had any feedback you'd like to share on those previous topics.
Yeah. Oh, sorry. Would you mind going back just real quickly? I was
Sure.
thinking, we've posed some sort of really big open-ended questions here, and a thought that just occurred to me is, particularly in thinking about the answers to the first question about this kind of how do we approach, how do we promote strategies or initiatives. We have a section of our framework, which we did include in the presentation today, around what we call our key levers. So we have some of the like drivers or levers, like benefit design, the measurement, data sharing, patient consumer education, those kinds of things. And I think in particular be helpful to hear folks responding, if it's a helpful framework to respond, as sort of what are the things that we dial up, dial down? What are the things that have maybe we thought would help but have proven less helpful? What are the things we should try that might be brand new that aren't even there? But that might be a useful sort of starting point for folks to kind of tackle these really big open questions we've posed. Thank you.
And it looks like there's a question about when feedback would be appreciated, so maybe that could be included in the email.
Yes, I'll go ahead and include that. We usually give a couple weeks, but I'll have to keep in mind all of the certification activities going on right now. And so we'll take that back and provide that in the email. Okay, so If anyone had additional feedback, you can always send that to pmdcontractsunit@covered.ca.gov to Diane Erkey. And our next meeting will be on July 7th from 10 to 11:50 a.m. with an anticipated focus on data and measurement. So we'll add those materials to the invite as we get closer to the meeting, and then we'll also provide questions and objectives prior to presentation materials as well. Are there any other comments or questions or feedback that anyone has based around the focus of this meeting, health promotion and prevention? Or any closing comments? Okay. Hearing none, I wanted to thank everyone so much for all of your time today, and thank you again to our guest speakers, Dr. Glassman and Dr. Jackson. We really look forward to hearing from participants via email, and we will see you all again on July 7th. Thank you.
Thank you.
Thank you.
Yeah.